Way. Good day, everybody. This is Joe Gallo from ASPI, and I'd just like to welcome you. Mark will give you a more official welcome, but I'd like to cover a couple of quick administrative points, if you don't mind, so that everyone is aware that this presentation, whether verbal or even material, is not intended to be recommendations for treatment or otherwise. We just suggest to you that you take this information to your doctor and discuss that with him or her. And with that, I will present to you Mark Lichty, the Senior Chief. What do we call you now, Mark? El Presidente? That sounds good.
You can call me Chair. Anyway, thank you all for coming. This should be a very interesting webinar. And I in particular want to thank the panel. This is a really expansive panel with so many different perspectives on this important issue of anxiety. And these folks just show up as volunteers. We don't pay them, and we're very appreciative of the fact that they care enough to show up. In this time together, we do our best to create an anxiety-free zone. I used to be a news junkie, but I gave that up just because it fueled my fears. It didn't bring me any peace at all. So know that you are not alone, and we're here to support you and support you even in trying to navigate the anxiety portion of active surveillance. I recall when I was diagnosed 17 years ago, the urologist told me that I had prostate cancer, and he was a friend and said, "You're Gleason 6, but I know you well enough to know that you're not going to have treatment." He did give me the phone number of someone who went on active surveillance, and I was grateful to him for that, but there was no nurse or social worker or support group or any more information to offer me guidance. And I didn't even know how to ask for guidance. You know, I'm a guy, so I'm not always that good for asking what I want. And so I was lost after that for a couple of years, and there was not even a support group for active surveillance patients then. I happened to visit my sister at Stanford, and I was able to find a support group with a couple of people on active surveillance, and that gave me hope. So ASPI is here to help you to navigate prostate cancer. And again, part of that journey is reducing anxiety. Thus, for this webinar, we scan the globe to see what the best practices are. If we know what they are, maybe we can ask for them and ask for more compassionate treatment. You'll hear of a breast cancer patient who had access to compassionate care, and not just when she was diagnosed, but it extended well beyond her diagnosis. And don't men deserve better than they're getting in terms of that? So I want to keep this short because we have a really good panel. Jeff, maybe you want to say a couple of words about funding and need for volunteers or whatever's on your mind.
Thank you, Mark, for a generous introduction. I also want to recognize Thrain. Thrain is with us. He's a board member emeritus, and he's calling in from Iceland. So welcome, Thrain. We're happy to have you. A little bit about California, and then I'll get into the job here. As you all may know, the United States went from the east to the west. And now, of course, some of you may have heard we're going from the west back to the east and other places. So if you have a Volkswagen bus, people are moving. You might find some value in that. Getting to the point, I'm the fundraiser person, and I'm thankful that we're all here this morning. And I just want to make this simple. For those of you who haven't given to us, why don't you, if you feel so predisposed, give us anything you want. I'm not asking for any certain amount. And the way I say that is because there's a concept called mutual recognition. We we do a lot of work for these programs and persons such as yourself, and particularly for our guests. And we want to continue that. We have some basic needs to cover, administrative costs. So if you feel so today, just drop a little something towards us. We have a donate button on our site, or you can contact me at gtmclennan, as spelled on the screen, at gmail.com. And I promise not to bother you anymore. Thank you very much.
So we want to get right on with the program, and my introductions are going to be very brief. I do want to thank Govinda, who's on this call with us, for his role in creating the program. Put all of your questions in the chat box. Phil Siegel and I will deal with the questions afterwards. So we hope you'll better learn from these presenters what's really available out there. So the first speaker is going to be Andy Steinfeld. And Andy, I'm just going to say that you're an empowered patient from Maryland, and you can do the rest of your own introduction.
Okay. Thank you, Mark. Yeah, I'm Andy Steinfeld. And I'll preface what I'm going to say by telling this is the approach I took, and it works for me, but it's not a suggestion that everyone should do it. Everyone has to make the decision that's right for them. And I'll share the story that I went through. The lead up was my PSA was rising. There was family history of prostate cancer with my dad, my uncle, my grandfather. So this wasn't a surprise, but I actually never had it on my radar. As it was rising, it was suggested I get a biopsy. So I got the biopsy, and now I'll set the stage. This was the fall of 2020. And as we all know, that's the year the pandemic started. Also, a couple of weeks before my biopsy, I'm an avid runner, and I took a fall on the trails and landed on my shoulder. So I had a MRI on my shoulder. I told my wife, I know it's 2020. I know it's been a rough year. There's no way I'm going 0 for 2 on these results. Well, I was wrong. The MRI result was I had a complex tear of my rotator cuff, and I had surgery scheduled for November 10th, 2020. My biopsy results were November 17th. And I walked in and saw my urologist, and he goes, "What did you do to your shoulder?" And I explained it to him. And his response was, "Yeah, that's painful. I had that. And by the way, you have prostate cancer too. And this is what we can do about it." So to me, that was very reassuring. It was very direct. It's really how I would have liked to have the news presented to me, and he even told me, he goes, "I can go through the whole spiel, but you're really here to find out if you have prostate cancer or not. And so let's just get to it and decide what we're going to do about it." And that, I appreciated that. He also handed me a packet, and it was called Hope and Help Every Step of the Way. And the first handout was, so I have been diagnosed with prostate cancer, now what? I was also assigned a Navigator, a oncology nurse navigator immediately. And I called her as soon as I got home. And she set up an appointment for me with a radiation person and a surgeon. So that's where I started. She was wonderful. My running partner's brother-in-law was the chief radiologist at the Mayo Clinic in Rochester. So I called him right away and I said, "Okay, what do I do?" And he was very helpful. A couple of friends from my running club had prostate cancer. I talked to them. I really took advantage of my network. And I actually had a friend's husband who just went through the process, as well as a neighbor. So I was surrounded with information from both the medical side of things and friends that I could talk very openly with. The radiation consult went very well, but he said, from our conversation, I can tell that surgery would be a better option for me. He could detect if I would say anxiety, he was detecting that I'd really like to just get this out of my system in the most direct way. So he said, radiation would work. but I think you seem more into a surgical approach. I took that opinion and went back to my friend from the Mayo Clinic, and he said his best advice was, if you're going to do a treatment like that, make sure it's curative or as close to curative. The odds suggest that it's as curative as it could be. So he suggested I should get an MRI. And I talked to one of my nurse navigator and said, you know, a friend said I should get an MRI. So she contacted the urologist and said, let's set up an MRI for him. And again, it was so nice having this person that I can go to and say, can you help me with this? We did schedule the MRI, and the results were, it looked like all the cancer was contained in the prostate. So surgery seemed to be a very likely curative option. So then I started with surgeons, and my first consult with the surgeon, you know, I was a bit anxious because of the pandemic. My wife was in the car on speakerphone. He seemed rushed. I told him running's very important to me. And I was worried about some of the side effects like the leakage. And he said, yeah, that might never go away. And, you know, if it would help, just drink less water before you run. Well, summers in Washington, D.C., that's not going to be an option. So it made me really uncomfortable. And that, I would say, was probably the lowest point of this whole process. But I called my nurse navigator, told her what happened. And this was hard for me to speak up and criticize someone of this magnitude. And she said, you know, I want you to try this surgeon. It's who I would send my husband to. And I also mentioned it would be nice if my wife could be there with me. She says, we'll make that work. So I met the surgeon, and it was interesting. I did end up talking to 4 surgeons, but this is the surgeon I ended up going with. And it was interesting because my first appointment with him, he was running about an hour and a half late. And I was already nervous from the first experience. But we went to see him. And even though he was an hour and a half late, he spent an hour and a half with us from 4:30 to after 6, answering every question we had, telling us everything he knew. It was just if there was anyone who was ready to end their day, it would have been him. And he showed no signs of that. So we ended up going with him. The other thing he did was, it wasn't just that he was going to do the surgery and he was well adept to do this. It was the follow-up care. He wanted to see me a week after the surgery. He wanted to see me every 3 months afterwards for the first year, and then 6 months after that. And that meant a lot to me. It's probably TMI, but you know, when I was down to 2 surgeons, one of the surgeons was like, yeah, after a week, you can take the catheter out. And I'm like, yeah, that's not happening. And this one was like, no, you're going to come in and we'll take care of that. So, you know, it's those little things that made such a difference. I'd also comment that the plan to make the plan was a really draining and hard process, especially with my limited medical knowledge. And the execution part was easier in comparison. So I'm happy to say earlier this month, still no detectable levels of cancer. My PSA is less than 0.006. And in the past year, I've run a 50K, a marathon trail event. So there's been no impact on my running, which is what was important to me. And I'm actually very happy at this point. So that's my story. So thank you for listening.
Interesting story, Andy, and particularly compelling is how the nurse navigator helped you find your voice. And that's precisely why I wanted to do this program, to help men find their voice and to ask for what they need. So that story is very relevant to today's event.
Yeah, Mark, I think, and not real quickly,
Sure.
I'm not sure how the story would have played out without having that nurse navigator.
Wow.
I think I might have gone to a different practice,
yeah,
and a different surgeon. So it still might have all worked out, but I think the road would have been a lot different.
yeah. Well, certainly less anxiety for sure.
Yes.
Yes. Well, anyway, I want to, again, thank you for that. And I want to introduce you to good friend, Bill Manning, who is also a board member and also has a Linda Ronstadt tribute band, in case you're looking for that. Bill, why don't you introduce yourself? You're a humble man, but I'm sure you can find the words.
I'll struggle, but okay. So, my prostate cancer, I'm Bill Manning. My prostate cancer journey started back in 2009. I like to say that it began with insurance. I was applying for additional life insurance, had to have a physical, and the physical came back with a PSA test that registered at 4.1. And of course, everyone knows that 4.0 is quote normal, end quote. So obviously I was a high risk individual and they turned me down. So I thought I would show them and go get a second PSA test. I'm a member, well, at the time I was a member of Kaiser Permanente Health Group. That's it's the largest managed care organization in the United States. They're not nationwide, but they're in many, many different states. They've been around for 70 some years. And anyway, I went to them and got a second PSA, and surprise, it was 6.0. So, so much for showing the insurance company how wrong they were. That then immediately led to a biopsy, which I did not question. I was assigned a urologist and really was completely, unaware of the steps in this process. So I got a biopsy, came back one core with 5%, 3+3 Gleason. And so the next thing I know is the urologist is discussing my options: surgery, radiation, or this thing called watchful waiting if you really, really want to. And emphasis on surgery, being he's a urologist. So at the time, the news was more devastating to my wife than it was me. To me, I looked at it as a problem to be solved rather than something, a Mount Everest sized problem. But here's where Kaiser kicked in. And I appreciated it at the time, but I appreciated it much more later on. And that is that I was assigned I don't remember the term that they used, but she was essentially a psychologist, but she really acted as kind of a intermediate resource to sit down with my wife and myself and then basically go over, but in detail, what the urologist had told us, because he, just kind of glanced through everything very matter-of-factly. And she actually took the time to go through each of the different steps, actually brought up side effects, and was willing to answer a whole lot of questions. The next key component, however, was she said, "Oh, by the way, we have a support group. Would you like to attend it?" And I thought, well, sure, why not? So I listed to get into that support group. It was a relatively small one, but nice group of guys. The one thing that was a little weird was it was a men only, but I guess they did that and they thought that, well, if there's only guys in here, they'll be more open about talking about anything. And there's probably some truth to that. So at any rate, attended a couple of those sessions. I heard across the spectrum responses from one guy who said once he got his 3+3 Gleason diagnosis, he wanted surgery immediately. He wanted it yesterday. He wanted that damn thing out. All the way to the other side of it, where a guy who had a 3+3 and had surgery, which was not very successful, and left him with very severe quality of life issues forever, and was a very, very angry individual. Very, very angry. So, I had to look at both of those ends of the spectrum and see what was up. Well, one of the guys at the support group came up to me and handed me a business card and said, "Hey, by the way, we know this other support group you might want to check out." And it was called the Informed Prostate Cancer Support Group of San Diego. And they met at the UCSD Moores Cancer Institute auditorium once a month. So I went to those several of those meetings, and it was like the light bulb went off. Here was a large group of men, usually 50 to 60 guys, complete across the board range of treatments, diagnosis, outcomes. I mean, you name it, it was in that room. And so what that enabled me to do was to talk to several guys that were on watchful waiting and get their spin on it. The other thing was the facilitator had a sheet to fill out, which basically was your whole history of what has happened up until now. And he said, "I'll be calling you in a week and we can talk more about what kind of questions you might have and, blah, blah, blah." So, it's a long story from that point on, but which of course I'm obviously still on active surveillance 12 years later. And I'm also still part of that support group, because I felt that I don't want to use the term "they saved me," but it was that kind of information and that kind of camaraderie and that kind of openness that basically you felt like, there were people that had your back. You weren't stuck in a cubicle with a urologist who wants to get you on the surgery conveyor belt. And to be fair, to honor my urologist's request, I did meet with a surgeon. I didn't bother meeting with the radiologist because by that time I'd already made my decision. I was not going to have treatment. I did bring my wife along on all of these decisions. She wasn't sold for quite a while, but until I laid all the facts and what I'd learned, what I researched and continued to research, she then got 100% on board and has attended PCRI meeting with me. I went to PCRI meetings, forever. And so the moral of the story was that, to Kaiser's credit, even being an HMO, they had the, if you want to call it foresight, to bring in a second person. I can't quite call her an advocator, but at least someone who was willing to take more time, ask more in-depth questions, not making you feel like you're rushed because the urologist has to get on to his next appointment. That was very, very important. And then the next part was the support group and the fact that they were willing to instigate that. And I'll bring up one last very important point. They also said, by the way, we have a voluntary spreadsheet that you can put your name on, when you were diagnosed, what your diagnosis was, and your phone number and your email address. And basically, this is offered to everybody that comes into the support group. And we'll leave it there until you tell us to take it off. And so this basically gave the opportunity for guys that came into the group to have a one-on-one conversation. And up until probably a couple of years ago, every once in a while, completely out of the blue, I get a call from that old spreadsheet that somebody, dug up and says, "Hey, I see you were on active surveillance. Don't tell me you're still on it." Okay, I won't tell you that, but I'm still on it. So that was, I think, another important part of what Kaiser was offering that in so many other medical environments, it isn't even on the table. So I want to say that was my support story, and that in so many cases, I think, as Mark has pointed out, we want to empower men to make more informed decisions, but sometimes they don't know what the questions are. And that's part of our job, is to get that information in front of them so they even know to ask for it in the first place, that it even exists in the first place, because so many guys look at this situation as something they just walk into, and it's, like you have a broken arm. Okay, I go to X-ray, I get a cast, and then I go home, not realizing that there are so many steps and things in between that can go right or wrong, and that you need some support, an advocate or a group to help you through that. Thank you very much for your time.
Outstanding, Bill, and thank you for that story. And part of the motive here is not to just learn to ask for what we want, but to show you examples of that it's happening right now in the United States. And, let's go to our providers and say, hey, this is going on over there in California or in Maryland or whatever. How come it's not going on in Pennsylvania? And it's not going on. My provider is Geisinger, and as far as I know, that's not going on at all. But there's plenty of examples where we can begin to put pressure on our providers in this way. Anyway, I wanted to introduce Dr. Madhavi. That's her first name, but I'm calling her Dr. Madhavi. And she's a breast cancer survivor and has a remarkable story of her own compassionate support that she received, which is way beyond what we males would normally get. And we should expect the same thing the women are getting, and we should demand the same thing that women are getting. So, Dr. Madhavi, why don't you further introduce yourself? She's a pediatrician from Toronto, by the way, and then you can introduce Robin.
Right. So hi, everybody. I am Madhavi Mohorir, and I was diagnosed with breast cancer in September 2020. As we all are aware, any cancer diagnosis puts a cruel break to our autonomous routine lifestyle. I think before this diagnosis, my everyday issues were reaching in time to my clinic during the snowstorm, juggling kids' activities, what's for dinner, etc., to suddenly juggling medical appointments, chemo first or surgery, genetics, etc. Close friends stepped in big time, but being in healthcare, I was aware how cancer, any cancer for that matter, but breast cancer, because I was diagnosed with one, the chronicity and its treatment can create many challenges, including personal, financial, and emotional setbacks. So I actually self-referred myself to the social worker program at Princess Margaret Hospital, where I was undergoing treatment. And I was lucky to have Robin Forbes from the Princess Margaret Hospital social worker department involved throughout my treatment, including chemotherapy, surgery, and radiation. She's actually still involved, although with less frequency than before. COVID restricted her involvement only through virtual sessions. And I actually met her in person only in December 2021. Robin provided tools and resources to help manage my stress. Through her, I actually came to know about programs like Wellspring, resources offered through the Canadian Cancer Society, and some practical information like transportation facilities, etc. Some of these, unfortunately, were discontinued due to the ongoing pandemic pandemic, so it gave less opportunities, but I did manage to look into or get involved in some of these programs. The second thing was that her counseling sessions were invaluable in maintaining my mental well-being. It also helped offset all the emotional baggage from my husband's shoulders. She offered continuous support without actually pushing any particular agenda. My biggest challenge initially was being completely honest with her about my worries, fears, and uncertainties. But I soon realized that once I felt comfortable to kind of bear it all, it really helped maintain my resilience. Right now, I am free of any active cancer treatment, and thankfully, hot off the press, my first surveillance MRI has been reported normal, so that's good news. But Robin remains one of my most important team members in my cancer management journey. So I think it's my privilege to invite Robin in for this webinar to talk more about her involvement, the resources available at Princess Margaret Hospital, and how invaluable their supports are when a person is diagnosed with I can say with breast cancer, but I think there are programs available for all kinds of cancer treatments. So that's Robin.
Hi, thank you. Thank you so much, Madhavi. Thank you. And thank you everyone for organizing this today. It's such an important topic. I'll just take a quick step back. Princess Margaret Cancer Center is an academic health sciences center in downtown Toronto, and we are a regional cancer center, which means we have surgical oncology, medical oncology, and radiation oncology all in our center, including urologists, of course. And through that, I work in the Department of Supportive Care, which is palliative care, cancer rehab services, and then psychosocial oncology, which is where I work. So I'm the clinical co-lead of psychosocial oncology, and I am a social worker. My focus is the breast site. So I'm a social worker for women with breast cancer and also mesothelioma, which is a lung cancer caused by asbestos exposure. However, our mandate is very much that every patient have access to psychosocial support. We know that cancer is not just a physical diagnosis. There's a significant emotional and intellectual impact with a cancer diagnosis that includes not only the person who has received the cancer diagnosis, but also their family members. And so right now, we are trying to figure out how we can be more proactive. Right now, we're a reactive department. We wait for referrals from the physicians or the nurses or the odd enlightened patient who reaches out to us, because we, of course, do accept self-referrals. My department is made up of social workers and psychiatrists who do a lot of supportive, expressive counseling. I know psychiatrists, often people think they just prescribe medication. And while they definitely can do that, they also do counseling. We're also very, very fortunate that our genitourinary service, the prostate service, recognizes the importance of psychosocial support. And the urologists themselves fund a psychologist. And so there's psychologists available for men who have been diagnosed with prostate cancer. There's often psychology trainees at the doctoral level being supervised in that. Pre-COVID, we also had a very active volunteer cohort from Prostate Cancer Support Toronto, and those men were right in the clinic. They were in the waiting rooms, and so they could connect with men at any point in their treatment to talk about, this is what happened to me, or I'm on surveillance as well, or would you, I know some of the guys were hilarious. They'd be like, would you like to see my scar? So really to connect where you are and offer that support. We also have a caregiver clinic so that partners and caregivers can also be seen independently and express their own concerns and worries. Ideally, we always want couples, families to communicate, because more often than not, you have the same worries. However, we also recognize the importance of having an independent space where you can share what you're thinking about. and get some direction and guidance, or just express yourself and your fears. Our prostate center, through our prostate center, so there is also a sexual rehabilitation clinic, or the SHARE clinic, to help if you are having side effects with impotence. And I think they might also deal a bit with incontinence. And there is a very active still peer navigation program connecting people. Everything, as Madhavi said, is virtual right now. We're still really locked down from COVID. Volunteers are still not allowed back in the hospital. And my work is still by and large virtual, so phone or video. We're part of the healthcare center. There's no, I mean, it's OHIP, it's different funding than the American model, but there's no additional cost to see us. And if for people who are having the more active treatment, if you're having surgery, if you're having radiation, if you're having hormonal shots, we will see people up to 3 years post-treatment. I think when you're in surveillance, your anxiety is very high. I know for the women with breast cancer, just waiting, like knowing that they're having surgery, but it's pending, that's a very difficult time when your anxiety is high. So we want to work with you to give you tips on how to manage that, a mindfulness focus about how to stay in this present moment, how to allow yourself to feel some of the emotions without worrying that you're going to be swept away. We really want to connect and offer everyone comprehensive support, and we know that that's important. I know that there's other speakers, so I will just leave it there. But thank you again for your advocacy and your actually focus on getting your psychosocial support as well as your physical care.
Wow, that is impressive, and we can learn from that. Another different question occurs to me, and thank you both so much for your stories. But the different question is, what's happening with active surveillance in breast cancer? I'm just curious about that.
It's not really a thing.
It's not a thing. How come it's not a thing for women?
We don't have enough data yet. So Madhavi, your doctor, jump in if you can help me. Like if there's what would be stage 0 DCIS, ductal carcinoma in situ, we don't know enough yet about what happens if it is not treated, and if it will potentially become a higher grade, or we do see women who have had early treatment that was solely DCIS that does metastasize. So at this point for breast cancer, the approach is still typically surgery and radiation if it's a lumpectomy.
Thank you. So lastly, I want to introduce Fotini Olin, and we went all the way to Sweden to bring her in, and she has a very interesting story. So she's a nurse oncologist, by the way, much experience. Go ahead, Fotini.
Yes, hello. I hope you can hear me now. My name is Fotini Olin. Do you hear me?
Yep, just fine.
Yep, good. Thank you for inviting me. You have gone a long way to find me, and I'm very grateful that you did. And I think I can contribute with my experience. I'm a nurse navigator, or a contact nurse, as we say in Sweden. But I think the best translation is nurse navigator. I have worked with oncology since 1988. I am a specialist in oncology as a nurse, and I have also a special education to be able to give advice, compassion, and guide a patient. So I think I'm kind of a mix of the first man who talked today, Andy Steinfeld. I think I'm like your nurse, and I think I do some of the work that Robin Forbes does. And that's what's expected of me in my role as a nurse navigator in Sweden. And I can give you an introduction of the philosophy that's the background to why we work as we do. Working with oncology for that long time, I know how oncology can affect a person's life. it can affect you in so many ways, depending on where you are in life. If you have just retired, or if you are starting a family, or if you're a single parent. I mean, the disease can affect a person in so many ways. And my job as a nurse is to understand what kind of patient I have, get to know the patient, and to provide the kind of support that the person needs. And to also encourage the things that really work in life for the patient and for his family. So if we are not now narrowing it down to prostate cancer, my goal as a contact or nurse navigator is to understand what kind of patient I have, what the family situation is like, and to support both medical and also as a nurse that I am. So in Sweden, the journey with the patient for the nurse starts when the patient gets his diagnosis. So when the patient comes to the urologist to get the diagnosis, I, as a contact nurse or a nurse navigator, I will be in the room when the patient gets his diagnosis. And that's when our journey starts together. So I will provide telephone number, email to make it easy for the patient to contact me. And if I'm out of work, if I go for a holiday or anything, I would provide the patient with someone else's contact number. So the patient will always be able to contact me. And we find that that's one of the crucial things to be easy to get in contact with, because then the patient pretty fast, the patient will understand that it's they don't have to call me 3 times to know if the telephone number is working. They understand that pretty easy. And then we also try to educate the patients. We think that's important to prepare the patients for treatment, to prepare the patients for biopsies, side effects of things. We think it's good to provide information before and during and after whatever they are going through. So we have like a care plan. I couldn't find a good translation, but it's like leaflets of paper that we put together for each and every patient, depending on the diagnosis, depending on the treatment, depending on what kind of needs the patient has. All in all, the sum of papers is about 160 pages. I mean, we can provide a lot of information, and we can control what kind of information the patient gets, because if we provide the right amount of information, the patient won't be able to, will not have the need to search the Google and the internet to find information. So we have a way of addressing patients so that they can feel safe and secure, and we can provide the kind of support that we think they need. So that's a crash course in the Swedish Nurse Navigator system. And this is provided for almost every patient. So this is really how we work for almost any kind of cancer disease.
Outstanding program, and thank you for filling us in on that. And it was that it, Fotini, or was there anything else?
That's it. If I get any questions, I can answer them. But I would like to add, if you want to feel that you are satisfied as a nurse, this is really the way to work, because you feel that you have the right amount of time for every patient, and it really doesn't take that much longer time. So this is time effective, and I think any patient that accepts the Nurse Navigator will feel that he's safe in a sense, because he knows who to turn to, and also for the family. Yeah.
Perfect. Well, actually, I don't see any questions in the chat room, but I think the panel has really given us an idea of how we can improve this whole arena. I'm going to do something different. Phil, do you see any questions in the chat room or not? I don't see any. So I think what we might do is, we haven't done this before.
Mark, David has a question. David Keller.
Oh, good. David, go ahead. Oh, well, why don't you ask it? Unmute yourself, David, and you can just ask it.
Okay.
I think we're going to do it that way today.
Can you hear me all right?
Yeah. Yeah, fine.
Yeah.
Okay. My question is, what about after-hour care? I ran into at least 2 situations where I was having an emergency post-biopsy at night, late at night. And I didn't have good aftercare resources. I did have the doctor's after hours, quote unquote, their answering machine, their answering service will then finally pick up, and then they'll finally reach out to a doctor, quote unquote, who's on call. But I found out that these doctors have, at least in my case, that weren't that, one wasn't really a urologist, was just sort of a nurse on call that wasn't that specialized. One was a doctor, wasn't really much of a specialist in this area. My point is that I was very unsatisfactory. And in fact, in my case, I got bad advice that could have caused me severe physiological damage had I listened to it. So what about after hours care? That's a big area, I think, of compassionate support to the urology patient that, at least in my experience, has fallen far short.
Are you thinking about the US or any of the panelists, David?
Anybody with any experience better than what I had. I'm in the Jacksonville, Florida area, and I, at the time, was working with a community urologist, and I had contact at a major medical clinic. Both gave me extremely bad advice on how to treat acute urinary retention.
Anybody
Can I
want to
respond
answer?
to this?
Yeah.
Can I respond?
ahead. Yeah, we can hear you. Go ahead.
I think if you are beginning to assess a situation and for example, do a biopsy, you need to take control over the situation. And as a caregiver, you have to take the responsibility to provide aftercare as well. So I think they should have provided you with information, and they should have given you telephone numbers to call that would lead you to someone who knew what was going on. So to a urology ward, for example, who has someone that really is experienced all the time, I think that's important. You have to take the responsibility over the whole situation as a caregiver. You cannot just do a biopsy and hope that everything goes well. You need to have a second plan and a third plan if anything goes wrong.
Thank you. I think it, from a technical standpoint, as I understand it, and anybody correct me if they have different information, but the bladder has a limited capacity. It tends to give you the need to urinate when you have about 200 cc's in your bladder. They don't like to see the bladder hold more than 600 cc's. And a good qualified nurse, if you're experiencing pain that sounds like urinary retention pain, a good nurse will quickly do like a sonogram to see if there's extra fluid in your bladder that's beyond its normal capacity. In my particular case, when I finally got to ER, they first took out 1,400 cc's. And the second time it was 1,800 cc's. And as I understand it, when you get to a certain amount beyond the normal capacity, it could send, urine up the ureter into the kidneys, and you can get terrible UTIs and kidney infections and things like that. So I just want to reiterate Mark Lichty's golden rule. You have to be your own best advocate. And it's really important for everybody on this call who's may go into a biopsy. They should know if you experience urinary retention, if it's during 9 to 5, get right to your clinic for a catheterization. If not, go right to ER. Don't let somebody tell you to take a hot bath like they told to tell me. My bladder was exploding up into my kidney, and I was told to take a hot bath by a doctor. I was told by a nurse at a major medical clinic, who was the after-hours nurse, just to tough it out. You know, I'll let you on the call, you know, make your own determination of the level of quality of that kind of advice. But just be aware that the 200 mark, the 600 mark, and urinary retention means emergency. It just means you have an emergency and you need to be catheterized. Thank you.
Just wanted, I can't turn my camera back on, but we have a 24-hour triage, nursing triage line that people could call into, and those nurses, you know, would have an algorithm of questions to ask you. They would alert your oncologist or direct you to, or urologist, pardon me, direct you to the emergency department. So that is a standard of care for us too, that 24 hours, there is a nursing triage line. And at night it's staffed by an agency, but then they have an algorithm of questions about unique to each circumstance and disease site that they can help and guide the patient and connect with their urologist or oncologist.
Thank you, Robin. You might query them on, if they get a call like this, you know, severe urinary pain after a biopsy, what is their triage list of questions?
So thank you for that. So the question from our board member Throne from Iceland, is there a nurse navigator in every hospital? I think in Sweden is probably what he meant.
Yeah.
But we'll leave it that way. So Fotini, maybe that's your question.
Yes.
Yeah.
There is a nurse navigator at every ward, at every for every group of cancer patients. And we have, I think we have about, Sweden is a small country. I think we have like 6,000 nurse navigators in Sweden that are educated. And we have a lot more nurses that work as nurse navigators, but maybe they don't have that title all the day. Maybe they do other things as well, assist with other things. But yes, we have a good group of nurse navigators. And since it's a good work, because it's an important work, and you really feel that you make a difference. In Sweden, we say that every patient with cancer has the right to have a nurse navigator, if it's a palliative situation or not, but they have the right to have one. So we try to offer patients because we see that we can help with a lot of anxiety. We can help to explain things time and time again. When the doctor says one thing once, we can explain, because we were in the room where the information was given. So we can explain, we can break information down, and we can give all the information, both in words and also written information. So I think we have like a key role in the cancer care. If it's active or not.
That would be extremely reassuring to anybody to know that that was available to them. I want to go on to Sean.
Can I just add?
Yeah, go ahead.
Fontini, thank you very much for your interesting information, because I have been fighting for years to have this kind of a system here in Iceland. We have nothing of this kind. So I have a lot of questions. I would like one day to have you, if possible, presenting to doctors in Iceland. Most of the doctors in Iceland, the urologists, they are actually educated in Sweden.
Really?
Yes. But unfortunately, I have not been able to get that, because I think it's so important. So I will just leave it to that, and hopefully one day you, if you would be willing to make a presentation both to patients and to doctors in Iceland about the system.
Of course, I would be glad to.
I'm surprised to learn 6,000 Well, that's a lot. I would like to have one in Iceland, and I would be happy. And thank you very much for your presentation.
Thank you. Thank you.
So Sean,
Mark.
Thomas, thank you for the question that you have here. It's surprising that today, I mean, that you weren't getting more information on support, and it's disappointing. I mean, I understand 17 years ago when I was diagnosed, but there's a lot out there, Sean. There's a lot out there even beyond ASPI. I mean, ASPI. Phil, did you want to say something, Phil?
Yeah, I just want to interject for a second because Sean is from Canada, as Jeff McLennan made a note. So Sean, I'll put in. We have an active surveillance group, a nationwide active surveillance group through Prostate Cancer Support Canada, which meets monthly. And I don't know where Sean is from, but I mean, if he's from a major center, there'll be a prostate cancer support group probably in his area. Certainly on the Prostate Cancer Support Canada website, there's a list of groups throughout Canada that he can access. And definitely, I think you may be alone. I would hope that the doctors would provide you with more information. But I think if you listen to what Bill Manning said, I mean, you really do have to be your own advocate, and getting more information and understanding what's involved in active surveillance is really important. And I think it's great that you came out to this group. I hope that you'll continue coming out to the groups, because going on the web, going to webinars like ANCAN has a weekly active surveillance meeting. We meet once a month. By going to these various meetings, you really learn a lot more about what active surveillance really is, and you learn a lot more about what the questions are to ask. Granted, you'd like to stay on active surveillance, like some of the veterans that we have on this call. Mark's been on active surveillance for, I think, 16 years. James Sims is probably the oldest. He's on for 17 years. I've been on for 16 years. And just being a member of a group, learning more about active surveillance just makes the journey a lot easier. You can live with active surveillance, or you can live with prostate cancer and active surveillance. You can live really, really well. You just have to sort of get your head around it. And that's to me, that's the biggest issue. You've got cancer, and people will say, gee, are you doing anything about it? Yeah, you really are doing something about it if you're on active surveillance. You're watching yourself really carefully. And if something has to be taken care of, you'll be well trained to know when that is and what to do about it.
Well, and I wanted to thank you for that, Phil. I wanted to add to what Phil just said. Phil is a thriver. He just spent, I forget, you're about 75, aren't you, Phil? 75,
I'll be 78 in April.
So okay. For Phil, the cancer didn't set him back in the least in terms of thriving. And our branding, our motto is learn, live, and thrive with ASPI. The cancer doesn't have to set us back in any way. We can choose to live fully, and we should choose to live fully. And that's part of our message as well. I just wanted to add to this, and then Sean, if you want to unmute yourself and talk about this a little bit more, you can. But let me add this too. There's other really good virtual support groups. ANCAN has a good virtual support group. There's online ones like the Inspire community. You post a question and you get answers back. And there's also Mail Care that has Health Unlocked. So there are so many resources now for men on active surveillance that didn't exist in the past. And it's a little sad that your doctor's not turning you on to all these resources. And but here you are. So now you know about them. Sean, do you have any other questions around that? Or are you good? You can unmute yourself if you want to.
Thank you very much. Yeah, I feel like I've had a very, very surreal experience because I found out about my diagnosis online on my own. We have a good system here for all reports and documents and lab results posted online to a portal that I have access to. And so I got that it was a Monday night that I got that information, and then the doctor called me the next morning. So I'd already had a chance to get the information, and then started Googling around to find out what else I needed to know right away. And then eventually when I had my appointment with him, he was very encouraging and assured me that since I'm low risk at this point, although later said I am really on the cusp of intermediate, but he says that unless I felt great anxiety, there wasn't any need for surgery, but then went on to explain all the details and negative side effects as well of both surgery and radiation, which reassured me that active surveillance is what I would like to stay with as long as possible. But beyond that, he didn't offer any recommendations or referrals for any other kind of support groups or anybody else to talk to about this.
It's too bad, and that's part of this webinar today, for us to help find our voices so that we can begin to speak to doctors about this, our providers about this, whoever needs to hear it.
Hey, Mark.
Is Sean,
Yeah.
where is Sean located?
I'm actually in the U.S., so I don't know how it showed up as Canada somewhere, but I'm in the U.S. in St. Louis,
Okay.
Missouri. So but thank you for the referrals to other links, because at least those have information there I could find.
Well,
and this,
we like the Canadian. We like the Canadians too. You can go to your thing is virtual. Your thing is virtual anyway, isn't it, Phil? I mean, you could go to that too.
Yeah, it is.
Sean?
Well, Joe can certainly help him with his website.
Yeah.
thank you.
If I could just throw in a quick comment relative to Sean's situation. Actually, I think his urologist should be commended, at least for the moment, for keeping him off the treatment conveyor belt at this early stage, because there's still loads and loads of urologists that at the slightest smell of cancer feels that you're now a candidate for treatment. So, you know, this is real early in the prostate cancer journey. And it sounds like the urologist is, willing to take baby steps in this rather than jumping off the cliff. So I think he should be commended for that.
Yeah, if I was to give you some comparison, Sean, when I was diagnosed, they told me I was unfavorable intermediate. So I was further along in yours. So I echo what Bill said. It's nice that it's a slow start, not throwing you right towards a treatment. And in my experience, I actually did have one of the surgeons say, even if you pick a different surgeon to go with, it would be good that you take care of this in the next few months. So just a point of comparison, if that helps.
Thank you.
Good. Well, let me ask if we're going to do this differently now. As I just said, if somebody wants to unmute themselves and ask a question, feel free to.
So I actually have a question for Robin. So Robin, the services which are available at Princess Margaret Hospital, I can see that's because it's a tertiary focused cancer treatment hospital, level 3. Sorry, if the other cancer treatment centers around Canada or around Toronto, which are not tertiary level 3, are there similar supports available, or is it through the general hospital social worker group? Because I feel that from the couple of other breast cancer patients and survivors I have talked to, it almost feels that I'm a little bit privileged to get this support.
It's an excellent question. Yes, I think because we are a regional cancer center, we do have more resources and more attention to psychosocial oncology. So like the bigger cancer centers in the province will have a more robust psychosocial or social work support, but some of the other smaller hospitals, you may have a social worker, but they could be solely focused on resource acquisition. They could be solely focused on drug coverage or getting you connected with income support programs, and they may not be as available for counseling and emotional support. That's a really good point.
Anyone else want to ask a question? Feel free to unmute yourself. Well, here's one. Okay, Fotini asked, how often do you
hear from the doctor that they have discussed your disease on a multidisciplinary round with other specialties? Do you hear that as a patient, that they have talked about you in rounds before you get to the appointments?
Anybody hear that?
I think it's particularly rare, actually. It depends on the facility, if you would have that. But unless it's one of the major centers of excellence or hospitals, they probably don't offer that.
No. Well, again, thank you for that. We need to find our voices. We men need to find our voices. We men need to ask for the things that we spoke of here. Now we know the models better than we had before this webinar. And now that we know these models, we can point to these models and begin the process. It's going to be a long process of change, but it can be an immediate process of change when you first talk to your urologist and say, hey, I want better support. I want better service. I want compassionate service. I don't know what your urologist will say, but let's ask for it.
In Thunder Bay, Ontario, where I am, I've heard the urologists say that they have multidisciplinary conferences on all of the patients. I don't know if that gets communicated to all of the patients, but when they've spoken to our group, they've talked about that. And so I guess that makes us fortunate.
Yeah.
Great.
Yeah, I think what Madhavi said is correct. In Canada, only the major centers and major hospitals has these services, not in other places. I checked that some time back.
Terrific. Well, if no other questions, I think what I'd like to do is ask the board and any program team members to just stick around for a few minutes, and if the rest of you could go out and enjoy your afternoon, that would be wonderful. And we're very grateful. This is a very informed panel, and it's been very educational. So thank you to the panel for what you brought, what you shared with us today.
Mark?
Yeah.
This is Joe. I just want to make one more admin comment because I forgot to. For everybody who wants to try to save the information that was in the chat, because there was a lot of stuff that got plugged in there. If you go to the bottom of the chat, there's 3 dots to the right side. You click on those 3 dots, and then it will allow you to save chat. So you don't have to worry about, did I copy everything down madly as possible?
Thanks for that.
So you can save the information that was in the chat.
Okay, terrific. Appreciate it. All right, well, thank you all. And so that's the end of the webinar. Much appreciated to all of you who attended. Thank you.